All right, let's jump right in. What we're breaking down today is a really crucial secondary analysis of a major phase 3 trial. We're going to be looking at second primary malignancies, or SPMs, in survivors of oral cancer. Now, for any of us who manage these patients, you know this is a huge deal. And this data gives us some of the clearest, most actionable insights we've had in a long, long time. And here's exactly why this is so critical. A second primary cancer isn't just a complication. It accounts for up to a third of all deaths in our long-term head and neck cancer survivors. This is not some rare event. It's a major driver of mortality that we have to think about in our clinics every single day. So just so we're all on the same page here, when we say SPM, we're talking about a brand new, completely distinct cancer. This isn't the old cancer coming back. It's not a metastasis. It's a second, totally independent fight for our patient. And it often comes from that same field cancerization effect we see, from years of tobacco exposure. All right, here's our game plan. We'll start with the clinical problem and the study's context. Then we'll take a quick look at the methods. After that, we'll spend the bulk of our time on what the data actually showed and, probably most importantly, how we could apply this to our own practice. Then we'll wrap it all up with a clear clinical bottom line. Okay, first up. This isn't just some random data set we're looking at. This is a secondary analysis from the OCAT trial. That's a big, prospective, randomized study that followed 900 patients with locally advanced oral cavity squamous carcinoma. So what that gives us is some really high-quality, long-term follow-up data from a very well-defined group of patients. So this analysis really gets to the heart of a question we all have. For these oral cancer survivors, what is the actual risk of getting an SPM? Where do they tend to pop up, and what factors can predict their outcome? Honestly, until now, good prospective data on this has been pretty hard to come by. So, you know the drill. Before we can trust the results, we've got to kick the tires on the methods. Was the study actually designed in a way that gives us reliable answers that are relevant to our clinics? The patient group here is super specific. They were all post-op patients with locally advanced disease. Almost all of them were tobacco users, and they all came from a single high-volume center. And the endpoints, well, they're exactly what we care about: overall and progression-free survival after that SPM gets diagnosed. This is what helps us understand the real impact of that second cancer. All right, now for the main event. What did the numbers actually say? This is where we get into the data that could really start to change how we counsel our patients and plan their long-term management. Here is your big headline number. At 5 years, the cumulative incidence of developing a second primary malignancy was 11%. This gives us a really solid perspective figure to use when we talk to patients about long-term risk. It means more than 1 in 10 of these survivors is going to face a brand new cancer within just 5 years. And where are these new cancers showing up? Well, this is a perfect picture of that field cancerization concept. A staggering 83% of the SPMs were right back in the head and neck region. The lung was a distant second. This tells us exactly where we need to focus our surveillance. Now, this might be the most important finding in the entire study. Look at the massive impact of how the SPM was treated. If patients could have their second cancer managed with surgery, their 2-year overall survival was over 66%. But for those managed non-surgically, it just plummeted to under 12%. The takeaway is crystal clear. Being able to offer a surgical cure is the single biggest factor for survival. And when they crunched all the numbers in the multivariate analysis, that story got even clearer. Only 2 things independently predicted better outcomes. Number 1, as we just saw, was attempting surgery. It cut the risk of progression or death by about 66%. And the second was timing. If the SPM showed up more than 2 years after the first cancer, outcomes were better. That probably reflects both the biology of the tumor and just being in a better position to tolerate aggressive salvage therapy. Okay, so we have this really powerful data. The big question is, now what? How do we actually translate this to our day-to-day clinic? And to do that right, we have to talk about the study's limitations. And think about how this applies to the patients we actually see.
This is the million-dollar question we always have to ask ourselves, right? The patients in this trial were from one institution in India, and almost all of them were tobacco users. So, how does this apply if your patient population is different? Say you have a much higher rate of HPV-related cancers.
Now, to their credit, the authors are very upfront about the study's limitations. First off, it's from a single institution, which always makes you wonder about generalizability. Crucially, they didn't have data on HPV status, and we know that's a whole different ballgame with a different risk profile for SPMs. They also couldn't track who quit tobacco after treatment, which is another huge factor. These are all really important things to keep in the back of our minds. So even with those caveats, this study gives us some incredibly powerful practice-guiding messages. So let's just distill it all down to the clinical bottom line, the 3 things you can take with you to the clinic on Monday morning. All right, here they are. Number 1, pursue surgery. The survival difference is just too big to ignore. If that second primary is resectable, that is by far the patient's best shot. Number 2, maintain vigilance. We need to be on high alert, especially in those first 2 years after treatment, because that's when an SPM carries a much worse prognosis. And number 3, plan for the long term. Don't stop looking after 5 years. A lot of these cancers show up late, which really argues for setting up serious long-term surveillance for these high-risk survivors.
And really, this all brings us to a final, big-picture thought. This data makes a powerful case that our best strategy isn't just about getting better at doing difficult salvage operations. The real challenge is about shifting the whole paradigm. How do we move from treatment to true early detection? How do we find these SPMs when they're smaller, easier to resect, and ultimately much more curable? That's the big question this research really leaves us with.